My name is Dr. Mark Getelman. I'm a fellowship-trained orthopedic surgeon at the Southern California Orthopedic Institute, and I specialize in sports medicine, arthroscopic and minimally invasive surgery of the shoulder and knee, and cartilage restoration. In this video, I will be discussing ACL reconstruction. The anterior cruciate ligament, or ACL, is one of the four major stabilizing ligaments of the knee joint. It connects the femur, or thigh bone, to the tibia, or shin bone, of the knee. It's about 2 to 3 centimeters, or an inch in length, and it's quite strong. Its main function is to prevent the tibia bone from moving anteriorly or coming forward, as well as to prevent the shin bone from rotating too far in a twisting position. ACL injuries can occur in different ways and usually occur in athletes. There may be a contact injury where the athlete's knee is hit from the side and twists, tearing the ACL, but perhaps more frequently, the ACL can be torn during sports activity with no contact whatsoever. ACL injuries can be diagnosed in many different ways, including the history of the injury and the physical exam, but most commonly an MRI scan is obtained to evaluate the status of the knee joint and the integrity of the ACL. Once an ACL injury has been diagnosed, there are important treatment decisions to be made. They focus upon initially rehabilitating the muscles around the knee to restore as much strength and stability from the supporting structures. This is often inadequate, however, to resume athletics, and surgery is typically recommended to reconstruct or rebuild the ACL. In order to move forward with the reconstructive surgery, the swelling must be reduced and the range of motion should be fully restored. Icing and oral anti-inflammatory medications can be helpful. As the inflammation is reduced, it is then important to get the muscles firing again, and physical therapy may be initiated. ACL reconstruction is a well-tolerated, safe procedure which has excellent outcomes typically. The surgery is an outpatient procedure, meaning that you go home the same day. The surgery itself takes 1 to 2 hours, and the recovery time in the surgery center is typically another hour or so plan a half day. Patients often use crutches and a brace for the first several weeks until the incisions are healed and the pain subsides. Most patients will begin home exercises within 24 to 48 hours of the surgery and then begin formal supervised physical therapy twice a week at about 1 week after the surgery. Each week after surgery, more weight can be put on the leg and the crutches and the brace can be discontinued. Physical therapy will help decrease the swelling, improve the range of motion, and increase the strength and function of the knee. Eventually, patients will return to sports. This process usually takes 6 or more months after the surgery to fully recover. Graft selection is an important decision and is individualized in each patient's case. Patients can choose to use their own tissue or an autograft. Either the patellar tendon or hamstring tendons can be employed, and both present excellent options for the ACL. There is some inherent recovery, though, from the harvest, and patients often consider allografts as an alternative. The allograft, or cadaver-donated tissue, can also be used and does not have the additional harvest risks or discomfort. The potential for disease transmission related to the use of allograft is very minimal and is currently reported at less than 1 in 8 million cases. Several studies have compared the outcomes following ACL reconstruction using both autograft and allograft. Most studies show similar outcomes. However, there may be a potentially higher risk for graft re-rupture in an individual under the age of 25, and allograft selection in this subgroup needs to be carefully considered. Regardless of the graft choice, ACL surgery is well tolerated, has excellent outcomes, and it should be expected. I look forward to meeting you and discussing my recommendations for your case specifically. Thank you.